Welcome to the 9th episode of the Ithacast. I'm Tuxton Witt.
And I'm Seth Murtaugh.
And I'm Katharine Celentano with the Drug Policy Alliance.
So, Katharine, we've usually started off these podcasts in the past with our guests introducing themselves and talking a little bit about their background. So, you're doing some very interesting work locally in the community. So maybe you could tell us a little bit about how you came to Ithaca and how you got involved with this line of work.
Sure. So, a little over 10 years ago, when I just graduated high school, I actually ended up in a residential facility myself. It was a dual diagnosis facility, which means that there were people that were there for addiction as well as for psychiatric issues. And so I was there presumably for psychiatric issues, but most of the people that were there were also there or were there for drugs, or they were there for drugs and something else. And something that I noticed very quickly that absolutely broke my heart was that people that were there as discriminated against as people were who were given psychiatric diagnoses were that for people that had a struggle that was related to a substance that was currently illegal, that in many ways it was illegal for them to exist. So that got me doing a lot of reading. It got me doing a lot of research. I started to get into some advocacy. And I eventually decided to go back to college, went back to college, studied psychology, continued to be involved in advocacy along the way, done a variety of things, worked in a neuroscience lab, worked in Capitol Hill, worked on a state prevention board in Vermont, and ended up here. And now I'm a policy coordinator with the New York Policy Office of the Drug Policy Alliance, which I am just so excited to be doing. We are the premier national advocacy organization that's working to end the war on drugs and create a paradigm where we focus on compassion, science, health, and human rights. And so I'm up here in Ithaca. I was really excited to do work outside of a more highly populated area. I was living in New York City for a while I was finishing school, but I had lived in rural Vermont for a while. And I missed it terribly. So, and there's just such exciting things that are going on in here in Ithaca specifically. So I'm really excited to be doing this work, living up here, and I'm happy to unpack any of that more, but I'll stop there.
So what are some of the things, like specific things that you've been working on in your role locally? Here
in Ithaca?
Yeah.
So a lot of my work has centered around providing technical assistance for various components of the Ithaca Plan. And as folks probably know, the Ithaca Plan was the product of the Municipal Drug Policy Committee, which Mayor Myrick convened several years ago at this point, and they released this report that had over 20 recommendations to address the harms that are associated with substance use and also the harms that are associated with the drug war itself. And so several that I have probably spent the most time focused on include advocacy for a local safer consumption space. Folks may have heard of that, called a supervised injection facility. They go by several different names. And also I've done a lot of work around the Law Enforcement Assisted Diversion program, which is a pre-arrest diversion program that is implemented within a harm reduction frame, and that specifically also tries to tackle racial disparities within the criminal justice system. So, for example, it contrasts itself from, say, a drug court in that the arrest never takes place. So you're diverting somebody from involvement with the criminal justice system in a more complete way, and you're also not prescribing specific treatment regimens to folks. Folks are given a lot more ownership and freedom to really decide what sorts of supports they feel ready for and that they would find helpful. So it's also a lot less prescriptive, and it's has some pretty good data coming out of it, as does the safer consumption space.
So what's the status of, I'm sure we'll talk about both of these, and these were probably the two biggest things that came out of the Ithaca Plan. At least the ones that I think have gotten the most attention. The supervised, you're saying it's safer consumption space?
Safer consumption
space got a lot of attention. There was a lot of national attention and media attention. But we've also, the county and the city have also been working to try to implement the lead policy. Mm-hmm. So what's the status of that currently?
Of which one?
The lead policy.
Of the lead policy?
Like, where does it stand with the city and the county?
So over the last year, we convened. So basically, there's a number of different components to LEAD. And one of them are these governing bodies that create a unique structure that permit mutual accountability between different types of stakeholders, between different parts of the community, and that also permit a sort of collaboration that we find, or that in other programs has been very helpful. So before you actually launch the LEAD program, you need to get those governing bodies up and running. So basically you have a group that's sort of like a board of directors called the policy coordinating group that includes sort of the executive decision makers from different parts of the community, from county government, from city government, business representation, as well as some community leadership as well. And then you have something called the operations work group, which develops policies and protocols. So for example, they would develop what the diversion criteria is. And then after launch, that group shifts into more of a case management body. And then also, while not implemented in every jurisdiction, Ithaca has selected to have something called a community leadership team, which is a place where community members with different backgrounds, whether it's relationships with community groups, direct lived experience of the system, or direct of the system, or of some of the issues that might lead someone to become enmeshed with the criminal justice system, can then have a meaningful involvement with the governance of the program as well, and also serve as a liaison to both get feedback from the community and give feedback back out. So those three governing bodies are essentially up and running. And so right now we're just in a phase where we're trying to match funding with hiring a service provider. And
the funding seems like it's been the biggest piece. I know that, just from being on the council, that's what we've been discussing, is how much money the county's putting in versus how much money the city's putting in, and all these discussions.
And what the numbers would be. So like we now have maybe $100,000 tucked away, but I think the need is bigger than that, $150 a year going forward or something.
Yeah. So, I mean, total funding, I'm not in my role. I was serving as program manager. I'm more of a facilitating role. I'm not a decision-making role. Right. So I don't want to speak on behalf of the program. But, there are different models that you could look at in terms of how you would structure staffing. There are really two components, two staffing components that are at a bare bones launch. So you need somebody who can do some of the administrative coordinating work that involves coordinating these different bodies. And then you need, of course, case managers that are directly working with clients.
So the other program that we funded is the community outreach worker, with Tammy Baker's position, which is essentially like an on-the-street social worker who's engaging with people who might have mental health problems or substance abuse problems. And it's been, I think most stakeholders would agree that it's been a successful program to date. And so there was a push to expand it. I mean, do you see that there could be some overlap with what Tammy's doing with the community outreach worker position? Because that does seem like it's potentially pre-arrest, right? Just in the sense that Tammy's working pretty closely with the police department already, and there's cases where she might be able to de-escalate situations before they'd ever lead to an arrest, or Tammy could hook people up with services if they need them. Is that something that you see that could potentially fit with LEAD?
So the neat thing about LEAD is that it tries to fit and collaborate with everything. And that's part of why you have the governing bodies and then the operations work group, which brings all of those different folks into the room at the same time. And I think that any support services, whether it's like, Southern Tier AIDS program doing syringe exchange, or Tammy doing the incredible work that she does with the outreach, or whether it's, a place like ADC or Alcohol and Drug Council, places that are providing any sort of support, or a housing support provider, all of those things, because we know that one of the primary drivers of a problematic relationship with substances or substance use disorder are these different social determinants. And so anytime that you're tackling those social determinants, you presumably are going to decrease you're going to be addressing negative outcomes, which would include, hopefully, decreasing the number of people that get exposure to the criminal justice system. So absolutely, that is, there needs to be massive collaboration there, as there would with any other stakeholder. I think the difference between those two programs is that LEAD very specifically does diversions at the point of arrest, making it a non-arrest, if that makes sense. Whereas the purview and exact mechanisms are different in basically other support programs, but all of these are part of the tapestry of what it means to support people, of what it means to have a supportive community, because no one component can tackle the complex challenges that face people.
So when you said that the diversion happens at the point of the arrest, is it ultimately the police officer that's making the decision about who would enter into the lead program? And the difference there would be that instead of like a judge with a drug court where the judge is diverting somebody, like the police officer is the one who says, okay, this person, I recognize that they have X, Y, and Z issues that qualify them for this program, and I'm going to make the decision as a police officer. I have the authority to do this, to divert them into this special program. Is that basically how it works?
So I'll speak in sort of the generalities of the lead model. In different jurisdictions, there'll be like slight shades of gray difference, but essentially there are a number of people that have to three different parties have to consent to the diversion, or at least two. It depends on the situation. So the person being diverted has to consent. The officer who would otherwise be making the arrest needs to consent, which is the component that you're talking about. If there is a quote unquote victim, so let's say that a person is being diverted for shoplifting, the business would have to consent. The person who is the person or the entity or person that is experiencing harm would have to also consent. And then sort of pulling back a bit from that, officers, have discretion in those contexts, but then the governing bodies are the ones that are creating the diversion criteria. So they're saying, this is the rubric by which somebody could be divertible. And so in that way, there's also a community consent, whether it's
right.
Government stakeholders or anybody that's part of any of those governing bodies that results in those final diversion criteria and also their oversight.
So just to help us understand this further, so once the person is diverted, it means they're not going to jail. So
for that specific offense.
What happens to them? What does it mean to be in the lead program then? What happens to them from that point on? They're not mandated to go seek out any kind of treatment, right? Which is, again, different than a drug court. Because in a drug court, it's like, instead of being sent to prison or whatever, we're going to put you through this treatment program. Right. In this case, it's they're free to go about their business. So what is the mechanism? Is there some kind of mechanism to, I don't want to say compel because maybe that's too strong, but is there some kind of mechanism to like help them access services, or can they just continue using? Is that like, and they will not be arrested for?
So a person being diverted, and again, because the Ithaca program hasn't launched yet, I'm going to speak in generalities about lead programs in general. And so once a person has been diverted or basically brought into the lead program, they've consented, the officer's consented, etc. That doesn't grant you immunity from future offenses, it doesn't grant you immunity. And so what it does is, so once here's the general, again, the shades of gray may vary by jurisdiction, but generally speaking, that process happens that I just explained. All two or three parties consent depending on the situation. The person who is being diverted to lead is then diverted into the lead, and then over a period of time, usually 30 days, they then have to fulfill the only requirement of the program, which is to do an intake meeting with the lead case manager, which doesn't necessarily have to happen that night. They will probably if best practices, they would literally make face-to-face contact with that person that night. That person would come out to the field, and basically the officer steps away, and that other support person takes over. But they, that moment, the chaos of that moment is not always the best time to have sort of the full intake meeting. So they need to complete that full intake meeting, and then they're in lead. And so that person could theoretically never make contact again. But what we've seen, and this has been implemented in a number of different ways, and also it's not the folks that are involved with the LEAD program. So the case managers, members of the operations work group, which typically involve officers that are doing LEAD, as well as, of course, the LEAD case managers, as well as local support providers. So folks from different local harm reduction agencies, from local treatment facilities, housing, really any entity in the local support system, will now be aware of the challenges the challenges that person may be trying to tackle in a more coordinated way. And as a result, there may be the opportunity for greater outreach. And so what that person then has access to is interaction with the case manager and sustained intensive engagement with that person in a way that cannot be destabilized by a framework of compliance. So yes, if somebody could absolutely continue to use drugs in the program, and that is foundational to the program, because the current way, generally, to zoom out from LEAD, one of the challenges or design problems with how we typically address problematic drug use in the United States is that we tell people, well, okay, you have a problem using substances, and we will not help you in any way, shape, or form unless you stop using the substance first.
Right.
So first of all, it sort of undermines our acknowledgement of the initial condition, which is by definition challenges associated with moderating one's substance use or changing the level of one's substance use. And it also means that we basically, we're abandoning the people who are at the highest risk, the people that are at the highest risk of overdose, the people that are at the highest risk of endocarditis or of any other sort of negative consequence associated with drug use, or the criminalization of people that use drugs, are the people who are actively using drugs. And so what LEAD does is say, hey, here's a stable presence in your life of somebody who will support you and find ways to make positive changes in your life, regardless of sort of your compliance status, and not even talking about compliance.
So that's what you're mentioning there speaks to two different philosophies about how to approach drug addiction, right? There's the abstinence approach, which says you should never do it, and that's the ideal, versus the harm reduction approach, which is where you're coming from with the Drug Policy Alliance. And a lot of these ideas like LEAD and the safer consumption space grow out of that approach, which is that you try to meet the individual where they are, instead of stigmatizing them and saying and approaching drug addiction as a moral issue, approaching it more as a public health, as a health issue.
Yeah, as a health issue. I can elaborate on that. Yeah, and I think, harm reduction's history now, the statistics that come out of harm reduction approaches are phenomenal. It's if you look at the literature, it's not really scientifically that controversial that you improve health outcomes. And so it's moved into this really public health sort of framework, which is absolutely appropriate. But I would say, and I think an important thing to remember about the history of harm reduction is that it was, maybe not even always that name used, but it was a movement that emerged from and by people that were pushed to the margins. So people who were engaged in sex work, people, people of color, trans people, and so forth, that were using drugs at the margin, and for a combination of reasons, were not able to access support. And so the harm reduction movement actually also has a lot of history wrapped up in the history of the HIV/AIDS crisis, because that was another situation where you had people that were very marginalized and at first not really getting the help that they needed. So people in these communities developed techniques to keep themselves safer than they would be otherwise. And it was sort of, a MacGyver do-it-yourself sort of way. And that's been going on for decades, and in many ways, basically since the beginning of time. People in complicated situations try to do the best they can with the difficulties that they face. And so more recently, it's moved more into the public health space because the outcomes are just so phenomenal, which is a great thing that it's starting to get, or that it's really getting that recognition. I think that while there are other countries that have really implemented it in a more it's much more central to those cultures and those countries' approach to substance use. It's certainly picking up steam and mainstreaming in the United States too, which is really important because it saves lives and a lot of people are dying.
And I think just just to say quickly that a lot of the stuff that you're doing is pretty cutting edge for the United States, right? And it's like really pushing the United States in a direction that's more similar to what some of these other countries have done. And I think also that does invite a lot of controversy. And I think that and also just a lot of confusion, right? Because people don't always understand what you're trying to do. And I think that's definitely been the case with the safe. I'm calling it a safer consumption space, even though I usually have called it a supervised injection site. So I don't know if you want to segue into that.
So yeah, about that. What is the term that you prefer? Is it supervised injection facility, safe consumption site, something else?
They're places that save lives. I don't get too married to what the name is. I personally think that some of the conversations around names are really interesting. And I think that, those conversations are important because they help us unpack a bit what the values are behind safer consumption spaces. And that's safer consumption space, I would say, of the names that I've heard. Speaking for myself, I think very well captures the spirit of them. It's a very comprehensive name. I know that New York City is calling them, and New York State now is calling them overdose prevention centers, which also makes a lot of sense to me. Sure. It's a center where people can come and get access to access to other supports, and it prevents death. And we're seeing an extraordinary amount of death due to overdoses that are as long as we're talking about an opioid overdose, these are completely 100% preventable deaths. But yeah, to the term safer consumption, I like that it's safer. It acknowledges that we're mitigating risk.
Gotcha. Yeah.
It's a space, which I think is an inviting name, and also acknowledges, if you look across the world, the different sorts of forms that these can take. Abroad, this isn't what's being discussed here right now, but you have mobile safer consumption spaces, or it's a space where people can avoid death and have it affirm that their lives matter and can receive the supports that they are ready for and or want. And consumption also acknowledges that there are multiple drugs that people use. So other countries are, that not everybody injects their drugs. So it's just a nice, robust name, and really that these places are about saving the lives and affirming the humanity of the people that use drugs. So
can you walk us through what the mechanics of a user would experience as they use one of these facilities?
Sure. Generally speaking, the model is as follows. A person that uses drugs brings pre-obtained drugs to a safer consumption space or an overdose prevention center. They go into the overdose prevention center, and at that place, they are able to use that drug under medical supervision, which has a number of benefits. If that person starts to overdose, that person's life will be saved. That person will not die because there'll be somebody there who can save the life of that person. And they're also protected from some of the other harms that might be associated with use. So, for example, if you're talking about injection drug use, somebody that there are other harms associated with injection drug use in addition to overdose. So, for example, endocarditis is an infection, a very deadly infection, a very expensive infection of the blood vessels that can kill you. And it can often arise from improper injecting techniques. So a medical professional can also not only reduce harm by stopping a person from dying, but from also helping that person reduce the harms associated with the fact that they're using. Say, hey, use a different angle when you're injecting. And then that person at the safer consumption space can then be connected with other supports. So let's say that person wants to detox from the drug, wants to detox and just quit drugs. There will be someone who can support them with that. Let's say that somebody doesn't want that, but they want, as I just explained, safer injecting technique, or that person needs help with housing. or that person, needs help with any myriad of things. And I think most fundamentally, I think one of the mechanisms of a safer consumption space, like you see some of these statistics, for example, coming out of Insight in Canada, where people that use the safer consumption space, you see a 30% jump in the number of people that do actually enter detox services. This is my opinion. I think that there is something absolutely, and it's measurably rehumanizing about having somebody bear witness to this highly stigmatized thing. And I think that is so powerful, and that creates so much trust that then permits people to explore things that may feel risky.
Yeah, that's interesting.
Treatment.
So more specific to Ithaca, and I should reiterate that there have been no concrete plans of any kind, but you made a comment to me once in private that I thought could, for many people, flip the switch on how they view them. And what you said was, imagine that STAP, the Southern Tier AIDS Program, was the one implementing the safer consumption site.
Whichever you prefer.
Whatever.
Place where people don't die.
Exactly. What would happen is STAP already runs a needle exchange. And if someone were to come in and grab their batch of needles, someone would just simply ask them, hey, would you mind using that here? And then direct them into a room.
Yeah. Yeah, you stated that well. And I think you're right. And I've explained it that way to other folks locally and even some folks who are still figuring out if they're supportive or not, and also folks who are supportive. And every time I see this light switch go off, because I think it answers some of the questions, that it makes it less scary. It sounds like this big scary thing that they do, in places that aren't America, and this big, revolutionary change. And it's a pretty practical, small change. And you just explained it well. People that are already going to STAP, people that we already know use drugs, people that, a lot of one of the questions that I sometimes get is, well, how does this work if the drugs are illegal? What sort of conflicts does that create with law enforcement? And if you look at what STAP does, for folks that are listening that may not know, syringe exchange means essentially that people who are injecting drugs can go to the Southern Tier AIDS Program, return or safely dispose of dirty syringes, and also get clean syringes. They are not able to use on site. They're not getting drugs from there. They're just, doing that. They can get access to or referrals to other support services while they're there. They can get access to Narcan, which is a life-saving overdose prevention drug. But as is, that's what STAP does. Everybody knows that. Or if you didn't know it, now you do. But that's what STAP does. Law enforcement knows they do that. And so every day there are people that go into STAP that presumably one could guess that maybe that people go in that building because they're using drugs. I rent an office in STAP, even though I don't work for them. I go in there. So, there are people that are entering that building that aren't using it for that reason, but law enforcement already know that. And the only change with a safer consumption space is is exactly what Doug just said, that instead of people going and using in a public place, you're actually taking that sort of drug use and you're reducing harm to the community as well, not just the person using drugs, because you're taking that public drug use out of the streets and putting it into this environment. And then those dirty needles are less likely to leave the building at all because somebody uses the drug and then they, properly dispose of the syringes. And, as I'm sure a lot of listeners know, if you look around downtown, there's a lot of businesses that aren't permitting folks to use their bathrooms anymore. Right. And that's something we're seeing in a lot of communities across the United States because folks are worried about people using in their restrooms. And so that's what it means. People use now, and they just need a safer, they need a safer place to use, and that benefits them. And it also benefits the community. So you don't have to worry about having a life-threatening situation on the premises of your business or in your park or the needles that can be disposed of there. Let somebody who's in a better position to support the folks that are having that experience do that in a place where there's medical supervision.
How about some questions that come right out of the Ithaca Voice comment section?
Oh, great.
Such as,
let's do it.
Aren't we just, if we support one of these facilities, aren't we condoning drug use?
We are not condoning drug use, but I appreciate you asking the question because that does get asked a lot. And I should say that 10 years ago, the first time I heard about a supervised consumption space, I was like, what? Because I got involved in this work because my friends were dying. And I was in a facility that was pretty traditional. This was an abstinence facility. You were kicked out for use very often. And I had friends get kicked out and then die because of that. So that's one of the consequences of turning your back on people, even if it comes from a place of good intentions. And so I not only understand that reaction, but there's a part of me that empathizes with it. And 10 years ago, I would have had that reaction. But there's a few different ways to answer that question. One would be, bottom line, you can't recover if you're dead. You can't improve your health if you're dead. You can't do anything when you're dead except be dead and whatever, religious next world may exist. And people are using drugs anyway. So this isn't really a question of endorsing or condemning drug use. This is a question of keeping human beings alive. And it's also a question of just looking at the data about what works. And it's pretty, the amount of data that supports safer consumption spaces is gargantuan. This isn't even something where we've had like a 5-year test run. They've been around for almost 4 decades on 3 continents in multiple countries. This is cross-cultural data. There have been millions of injections at safer consumption spaces, and not a single person has ever died of an overdose at one. And so, the number of lives that are being saved is astronomical. Jurisdictions see cost savings. You prevent one emergency hospitalization for endocarditis, and depending on the nature of that stay, an endocarditis hospitalization can cost tens of thousands of dollars. The amount of public funds that saves. You're seeing improvements in public safety, reductions of bloodborne illness, whether that be HIV or hepatitis C. And, we're all sort of connected somehow on the fluid chain. So that, as they say, or a lot of people are, so that means that you're reducing that risk for everyone in the population, even people that aren't using drugs, and people that aren't injecting drugs. And so the amount of data is just on all indicators for community health, fiscally, people that use drugs is just so positive and so consistent across context that one very simple answer to that is just look at the data. We're saving human life, and that's really the base. That's really it.
What about the criticism that supervised injection site, safe consumption space,
whatever you want to call it,
will attract users to Ithaca? Like little old Ithaca is going to suddenly be inundated with.
That's right. People will come from 500 miles away to do drugs here and attract every drug dealer in the region to Ithaca. And
connected to that you're going to see a deterioration of public safety in neighborhoods where these are located. And Ithaca it's not a big place, right? Where the facilities have been opened, I think, Vancouver, maybe Toronto. These are big cities, right? So how do you address those concerns that, one, it's going to attract a lot of drug use and a lot of drug dealers, and two, that there's going to be some kind of negative neighborhood impact,
Sure. All very, very good questions. And luckily I have good answers.
Better.
Yeah. And those are common questions as well, and reasonable, but, luckily the answers are pretty powerful. That, first of all, I would go back to the data that in all of this research, you just simply don't see an influx of people traveling to the site. And there's a number of different reasons for that. One of them is that people that are experiencing a chaotic relationship with drugs are unlikely to get up and be organized enough to sort of relocate themselves or make a large, travel plan to go somewhere. Safer consumption spaces typically have the largest effect in the close vicinity of where they are. And so the very simple answer is that, these places, that's just not what we've seen with the data. And again, we have a lot of data. And there have been a variety of location sizes of places that, a lot of Vancouver is one that gets mentioned a lot, which is obviously much bigger. But there are smaller locations in Europe. But the other thing I would say is that it's really important to look at safer consumption spaces, or the debate around safer consumption spaces in the United States, in the historical context of discussions that were had during the HIV/AIDS crisis with respect to syringe exchanges. And so, because the arguments that were made are basically identical. It was, we're worried that this is going to attract drug use. We're worried it's going to condone drug use. We're worried that it's going to create a problem for law enforcement. And that question actually came up as well, specifically in New York State of, well, we'll try this in New York City, but we don't really know what the impact would be in a small community upstate. And so because of that debate that happened previously, there was actually a delay in Ithaca's implementation of a syringe exchange. And people, died and got sick because of that, local people. And syringe exchanges are one of the greatest public health success stories of the 20th century. I mean, just dramatic improvement metrics that you just don't see anywhere else. And so, and the other thing to keep in mind is that there are a number of different reasons why. I mean, there's sort of a longer conversation that could be had, but in short, that if you look at the different where people are dying in the United States, often it gets framed as a really rural, suburban problem, and that's not actually entirely accurate. If you look at certain areas, so for example, in New York City, the Bronx has a death rate on par with West Virginia, which often gets a lot more attention in the press. Right. But to the extent that this has been something that has hurt smaller areas, how could our solutions exclude those areas, especially when there's so much data behind them? So it is essential to implement locally. And like we already know the syringe exchange works here. It would make perfect sense just to make this simple, minor change and save some lives, because we know that Tompkins County last year set a record for the number of overdose fatalities, and that its overdose rate had increased by 10 times in the previous 10 years, 1,000%. So,
actually, I'm glad you brought that up, because there has been a nationwide spike in overdose-related deaths, and I was wondering if you could talk about why that is, what's behind that.
That's a great question, and unfortunately, there are many causes. There are many reasons why we're in this mess. Why you've seen such a sharp increase in the last couple of years has to do with the adulteration of the illicit supply. And so first that meant fentanyl, and now you're starting to see carfentanil. And these are substances that are much more deadly than heroin. And they're not showing up in the supply consistently, in consistent amounts. And that matters and increases the death rate as well. So for example, if somebody is injecting what they perceive to be a stable amount of heroin, and their supply from their dealer gets adulterated with some fentanyl, they may have just taken a much more potent dose than they expected, and they may overdose and die. And the same thing with carfentanil, which is much more deadly than fentanyl. So part of what you're seeing where there are these overdose spikes, or even abatement of overdose. So there was actually an article in the New York Times, I believe it was last week, maybe a little bit earlier than that, about a town in Ohio, where they've been doing, a lot of really great local things about saturating the local market with, or the local population with naloxone, which is an overdose reversal drug. And they've seen a pretty phenomenal decrease over the last year or so of their overdose rate. But what they've also seen, which is not to discount a lot of that great local public health work that's happened from a harm reduction framework, but they've also seen a decrease in carfentanil in just the local supply within Ohio, or within that region of Ohio. And so there are a number of reasons why this is happening to think about. So first of all, this is one of the consequences of a black market, right? This is when you don't have a regulated supply, this is what happens. And it's also a challenge that gets exacerbated by a oversimplified narrative that just blames big pharma for what's happening, which isn't to say that there hasn't been a problem with prescribing customs and information and, getting good information to prescribers and to patients. But a lot of these increases of the death rate that you've seen in the last few years, where you've just seen the line, the slope line go vertical, have happened at the same time as the implementation of PDMPs, prescription drug monitoring programs, which are essentially programs that disincentive that make it harder. It basically cuts people off from their legal supply.
Oh, wow.
So you have people that are already addicted. Yeah,
That's crazy. Interesting.
then get pushed
So
into the black
talk about
market.
unintended consequences.
Yeah.
Right. Wow. So, with the safer consumption space, I mean, one difference with lead is that it's currently illegal under New York state law. So lead, if we could get our act together, we could set it up tomorrow. But the supervised injection space, I mean, we're really waiting on the state to legalize this, correct? So, what is, like, based on your knowledge of, your with the Drug Policy Alliance, like, what's the current status of those efforts to really try to push the state to make this legal?
Governor Cuomo needs to make a very important gift this holiday season, and that is the gift of life, because his constituents are dying at record rates. And all that needs to happen is the health department, with this New York State Health Department, which reports to him, needs to authorize safer consumption space research pilots. That is the only thing that is holding this up. This is the same method that was used to implement the first syringe exchanges. They were initially done through this exact same pilot structure. And despite the fact that you have mayors like Mayor Bill de Blasio, the NYPD in New York City has called for the authorization of these pilots. Entities like, of course, Mayor Myrick. How could I neglect to mention that? Who was actually the first one in the state to go out and lead on that, and really the rest of the state has been playing catch up to him. And he, what happened here in Ithaca really, I think, helped, gave an example to the rest of the country. But, you're seeing the endorsements of medical associations, the American Medical Association, the New York Association of Family Physicians. And I'm not really sure why it's been so hard for Governor Cuomo to play catch up, because people are dying. And just like with HIV/AIDS, and I think that you guys are doing great here. You're both elected officials who have invited me to speak, on this podcast, and you've been so wonderful in local conversations. But just like we look back in disgust and judgment at politicians who fail to act during the HIV/AIDS crisis, I think that it will be the same here. So, I'm hopeful that he will, without delay now, really, because we're out of time, authorize the pilots. But until then, the people who elected him will continue to die. Another essential thing to think about and remember in trying to understand why so many people are dying right now from overdose is the racist origin of the war on drugs. Our drug laws are all of racist origin at different points in our history, and certainly the history of opioids is no different. So, the solutions that we currently have, or that we don't have right now, harm reduction solutions, all of these things that we know save lives, have been around for decades. Some other countries have been doing these for a while. And one of the reasons why the United States is so behind is because we, up until very recently, perceived people that use drugs, and in particular that were using heroin, as quote unquote inner city and people of color. And more recently, that narrative has changed, although not necessarily the reality, but the narrative and public perception now is that people who use drugs, or people that in particular are dying of overdose from opioids, are middle-class white people who live in rural and suburban areas. Now, when we perceived the face of drug use to be different, we reacted with a historic escalation of the incarceration of human beings. That sets us apart from other countries and also sets us apart from any other time in history. And once there was this one of the things that's happened now is because this perception of who's using has changed, we're more willing to talk about public health. We're more willing to have an open discussion about words like recovery. And we're more willing to consider harm reduction. But the fact of the matter is that if we had had the same compassion for communities that have been experiencing overdose for decades, the overdose crisis is not new. We've had a recent spike in the numbers, but people have been experiencing substance use disorder and overdose for a long time. And if we had reacted appropriately earlier, we would already have all this health infrastructure in place. And that means that we wouldn't be seeing the overdose rates that we're seeing right now. And what I think is important to note there is that if it teaches us the lesson, or it's a demonstration that if you don't support people because you lack compassion for them, or if you're not introspective about that, it eventually harms the whole society. And so right now, our history of racism in terms of how we respond to drug use and chaotic drug use is now killing white people too. Not that it was killing white people before, but the numbers are changing. And so the lesson, I think the important lesson is for all of us, is to try to be aware of when we're lacking compassion, and to just not do that. We have to find solutions to, both the harms associated with drugs and the harms associated with the drug war that lift up everybody, marginalized people, less marginalized people. And we need to, create infrastructure so that we end the current crisis and we prevent future crises for all people.
Well, related to that, and I know you've covered this already several times throughout this interview, but because it's an issue because it's a belief that makes me so angry, I want to bring it up again just to reiterate it. And it is this view from some people that drug use is a moral failing. It's not a public health issue, as more enlightened people are trying to frame it as. And so I'm just curious what your thoughts are about that specific viewpoint.
Well, drug use is not a moral failing. And there are a number of different reasons for that. Everybody does something in varying degrees and varying forms that other people may judge as maladaptive. Some people eat a lot. Some people, use drugs a lot. Some, we all have sort of these avoidant things. And going back to what I said in the opening about this sort of realization I had when I was when I was in the residential facility, that really struck me, was the contrast of how the behavioral struggles that people experience, the responses to those were so different when there was a substance. So, for example, I had a friend who, was struggling with some substance use, had, what a so-called, what in so many words was called a relapse, left the proximity of the facility and was promptly arrested. To the facility's credit, it was a very traditional abstinence-based facility, but they, entered into an immediate sort of negotiation with local law enforcement to try to get this guy out of jail. And it was sort of this big hoopla that was not helpful to him. It was a waste of police time, and it was certainly traumatic for the rest of us that were at the facility. On the other hand, I had a friend there who was struggling with bulimia, and she would relapse all the time. But we know the police never got involved every time she relapsed. Mm-hmm. And from, a health perspective, both of those quote unquote relapses were taken seriously. They were discussed with the care team. There was an assessment about why it happened, how there could be better support. Was the framework wasn't perfect. There wasn't enough harm reduction at the place I was at, but that was disrupted by the presence of the criminal justice system, or sort of this more moralistic way of looking at drug use. I think that another thing that's really important for people to understand is the extent to which trauma is a predictor of addiction. It is easier to, there's a stronger connection between severe childhood trauma and addiction than there is even between a drug use and trauma. So a lot of people may not know this, but for every drug out there, including heroin, less than 20% of the people who try it become addicted. It doesn't mean you should go out there and, roll the dice. I'm not telling people, I'm not providing advice of any sort. But it does change our understanding of why people use in certain ways, and should inform how we respond to them. And, if people that are coming in to get support for truly chaotic drug use have suffered so greatly in ways that aren't even related to drugs. They have been failed by so many people in their lives, by so many different systems. And I think that was one of the reasons actually why I also got involved in this work, is because I noticed, especially because the place I was at, there were a lot of people who were young adults, meaning, hadn't turned 20 yet or in their early 20s. So really this cusp of the transition from childhood to adulthood. And what emerged for me from that experience was I noticed that there were all of these, at least in that slice of my experience, that you had all of these children that had been failed by the adults in their lives, that had been, some of them, abused in just extraordinary ways that I hadn't even read about in books. And the system and these different structures and some people that they were coming into contact with were not understanding or respecting the robustness of what they were going through, and were basically saying, this is all your fault. And I mean, it's just the most crushing thing to intimately see the struggle that somebody can experience as a child, and have that child reach adulthood, kind of struggle with the transition and be told, well, this is all your fault. It's a repetition of the abuse. So I think that if we look at drug use in a moral way, it's, if the purpose of morality is to help people live better lives, I think quite measurably, all we do is hurt the people that need the most support by looking at it that way.
I mean, it seems to be like the issue is does the society take a punitive approach, or more of a medical, or I don't know what you want to call it, like a public health approach? Because I mean, the only thing I can think of in my own life is like cigarettes, which I was very, very addicted to throughout my 20s, and tried to kick 3 times, and each time took probably a year, and there was a lot of relapses. And I've often thought about this, that if every time I relapsed, like the police got involved, I would have been arrested hundreds of times probably. But that's not what happened, right? Because cigarettes are legal. They're discouraged, which I think is an important distinction. Mm-hmm. Because just because you legalize something doesn't mean that you're like, it's not like a wholesale invitation to use this drug. The society can still discourage the use of it, as we do with tobacco. But I mean, that's an example of it, that society doesn't treat tobacco addiction in the same way that it does heroin addiction or addictions of illicit substances. And I think, it seems like the harm reduction philosophy is moving more in the direction of trying to treat other drugs the way that we treat, say, alcohol, or treat, tobacco, and now very quickly, I think in the state of New York, soon, marijuana.
Yeah, that would be the hope. And I think that the cigarette analogy that you just gave is so powerful. And I think actually, to the point about marijuana in New York State, highlights something really important. So when we talk about marijuana legalization, a lot of folks or conversations that have happened around marijuana are just like, okay, well, we should just legalize marijuana. But the fact of the matter is that historically, there are certain communities that have suffered more under marijuana's prohibition than others. And so, for example, imagine you had been arrested every time you relapsed on that cigarette. That would be annoying. That might result in a night in jail. But it would have a whole lot of other collateral consequences. It could mean that if you were a parent, you would have your kids taken from you permanently. It could mean, into a closed adoption where you don't get to see your kids again. It could mean that you aren't eligible for scholarships. It can mean that you get raped in jail. That happened to one of my friends too. They were arrested for something marijuana related and they got raped, and that is not healing at all. It could mean that it interferes with your ability to get employment. And so part of the awfulness that is awful regardless of who it happens to. But when that sort of harm is inflicted on entire communities and social networks and ecosystems of people, it's devastating. And as we know, like, basically all of the drug war, that has been experienced primarily of poor people, people of color, and in the case of marijuana, and especially in New York State, Black people. And so when we try to undo the harms of prohibition, we have to be thoughtful about that in terms of how we implement it. So something that's really important in how we're looking at marijuana legalization in New York State is trying to look at how can we make sure that once a legal market is created, that the people that benefit from that are the people, all of that, tax revenue that starts to come in, all of those folks that are able to, make a lot of money off of the legalization of marijuana. How can we prioritize the communities that have been so harmed, that have basically, through prohibition and its collateral consequences, had resources extracted from them? So, for example, some things that are foundational to the legislation that, we at DPA are strongly supporting here in New York is, it involves the sealing of records, which means that you can't be excluded from entering. You can still get a license even if you have a prior conviction. It means making sure that there's not too much vertical integration in the industry, and that we're providing micro licenses so that the barrier to entry in terms of initial capital that's needed is not so high that it's insurmountable for people that are already experiencing marginalization, because legalizing marijuana or even quote unquote ending the drug war, these aren't things that will end racism. But if we're going to try to undo the harms in which the drug war has been used as an instrument of racism, we better make sure that our solutions are doing what we say they are, which is trying to address some of those very serious harms. And that's why I'm not a person that uses marijuana. I don't like how it smells. I'm like a complete nerd. But for me, and I think this is so important, the first person to ever talk to me about marijuana legalization was a friend, and we were on our way back from a 12-step meeting. And we were just seeing really bad things happen to our friends. And this person was just like, I can't take it anymore. There has to be a better way. And that was over 10 years ago at this point. So, legalization of marijuana is not about marijuana. It is about human beings and the awful things that happen when human beings unnecessarily experience contact with the criminal justice system.
Well, thanks so much, Katharine. I would encourage, I'll put this in the show notes, but I would encourage everyone follow Katharine on Twitter. Her handle is Celentano, Celentano. You always have really thoughtful things to post, which, extend my education and openness to the world. But thanks again for being here with us tonight.
Yeah, thanks a lot for coming on the show.
Oh, thank you for having me. It's been a pleasure.